Greetings and salutations, East Africa. Welcome to your world on this cold and rainy morning, at least from Nairobi. Hope you had a restful weekend. Now, cancer is the second leading cause of death in the world, and in Kenya, cancer is actually the third leading cause of death after infectious diseases and cardiovascular diseases. Now, the world marked the Cancer Awareness Day on the 4th of February, which was last week, and though we have made great strides in the prevention, diagnosis, and treatment of this disease, a lot more needs to be done. Now, this morning, we have a cancer dialogue among stakeholders and, most importantly, those who know how this shoe pinches. I'm talking about the survivors. My name is Gladys Gachanja, and this is Your World. Today, as I mentioned, we take stock of the effects of cancer as we acknowledge the Cancer Prevention Awareness Month. Three robots navigate the hotel sky corridors, answering guests' queries, among other services. And still on the conversation of cancer, Aga Khan University Hospital launches a clinical research unit. And health workers in Pakistan are thankful to be receiving vaccines. Thank you for joining us on the broadcast. And as I mentioned, today we are taking stock in as far as how we are doing in the prevention, diagnosis and treatment of cancer in Kenya. So on that note, our question of the day to you is, do you know someone who is battling cancer or someone who has succumbed to cancer? Send a message of hope and condolences using that hashtag New Normal, because we know a lot of our loved ones have succumbed to this, and we all have a thing or two to say about the experience of actually battling cancer. Before we get to that vital conversation, let's take a look at the effects of COVID-19 around the world. And this morning, those numbers stand at 106,684,623 confirmed cases of COVID-19. Out of that number, 78,530,076 have totally recovered, and 2,327,249 people have succumbed to COVID-19 globally. Now, we might not have those numbers on the screen, but here's the outlook for Kenya. 101,819 confirmed cases this far. 84,361 people have totally recovered from COVID-19, and unfortunately we have lost 1,779 Kenyans to COVID-19. Well, remember, those numbers are updated on a daily, actually by the hour, and we shall always give you an update of the same here on Your World. Now, a look at some of the stories making headlines this Monday morning, and the next few weeks are going to be tough in Tunisia as doctors are worried about the continuous increase in the number of COVID patients, putting a strain on a fragile health system while the vaccine is overdue. Now, Dr. Amira Jamusi, a resuscitator at Many hospitals, says priority is given to patients who are more likely to survive. At first, this was not something that was welcomed with open arms. Some colleagues sometimes did not understand. It's true that everyone has the right to leave, but a resuscitation place is very, very precious. And we find ourselves in the situation where we choose between the patients, and patients can wait 72 hours for a resuscitation bed. And sometimes the bed does not come free, and unfortunately, we have deaths in the emergency room. Elsewhere in Johannesburg, 3 robots navigate the corridors of the 453-room upmarket Hotel Sky, answering guests' queries and delivering room service orders. Now, put in place before the pandemic, the hotel has embraced the new technology even more than it had originally intended as a way to help reduce the risk of infection by COVID-19 in a country that has recorded nearly 45 deaths.
Here are your results.
A lot of the guests think it's like pretty cool. I mean, the novelty of the whole system is big in South Africa. So the chatbot is pretty interesting because these robots have quite a catchy personality. So the replies are quite interesting that you get out of the robot when you ask questions.
Equinox Restaurant is open from 06/8:30.
The replies are quite interesting that you get out of the robot when you ask questions. In a hurry, but they sort of help out with the smaller things where people need smaller things, and where staff would usually be running up to 4 floors to deliver a meal or delivering 2 meals. Now we've got the facility where they can control the robots themselves and send it off, and they can also have the chatbot answering questions that would have usually taken up time for them. Database of questions and answers is forever growing. It would seem like the robot's not as smart right now, but with time, as more unanswered questions come in, more staff put in more, hotel-specific questions, it will seem smarter as time goes on. So that's the feedback loop for the learning of the robots for the chat-based system.
Hasta la vista, baby.
It just creates such a nice vibe and excitement for the staff, and then the staff have that in South Africa for all, especially where they have the opportunity to be part of this journey and being the innovators in South Africa hospitality trend.
Sorry, I don't know how to answer that. Can I rather search the internet for you?
So, did we switch on?
Now abandoned by their parents, hundreds of Cape cormorant chicks, an endangered species, are cared for in a seabird clinic. They were recently rescued at the southern tip of Africa and brought by boat from Robben Island to the clinic, where volunteers care for the little orphans daily.
So we rescued 1,800 Cape cormorant chicks from Robben Island. That was on the 12th and 13th of January. And going forward, we will probably start looking at releasing the bigger birds in the next 3 weeks, hopefully. And the smaller birds will obviously be here in the next 2 to 3 months. What we're scared of is this is going to happen more and more in the future. If they're not finding enough fish in the wild, what's going to happen? They're going to either stop breeding, or if they do breed, they're going to just abandon if they're not finding enough food. And what's the knock-on effect of that is that the population continues to decline until they become extinct.
Now to the focus of our conversation this morning, and Kenya recorded 5,236 new cases of cervical cancer in 2020, with about 3,211 women dying from it. Now, the Ministry of Health has further stressed the need for early screening so as to avert an increase of cases this year. During the launch of the Cervical Cancer Awareness Month in Nanyuki on Tuesday last week, Kenyans were urged not to shy away from screening. Cervical cancer deaths are set to go up by at least 50% by 2030 if no action is taken. Now, the Director of Medical Services in Preventive and Promotive Health, that is Dr. Pacifica Onyancha, led a Ministry of Health delegation in conducting an awareness walk in the town where residents received free screening services. This drive is informed by the reality that cancer is the 3rd leading cause of death in the country after infectious and cardiovascular diseases.
Msione kama ni msaha. Kansa iko, kila mtu ajitokeze, apimwe, ajulikane mapema. Na ukijulikana mapema utatimbiwa na utapona.
Kenya has adopted the WHO global strategy to accelerate cervical cancer elimination as a public health problem with 3 key initiatives and clear 2030 targets, namely 1, increase of the HPV vaccination to 90%. I'm glad to know that we are at 70% as a county.
So clearly that gives us perspective in as far as how we are doing with some of the cancer cases in the country. And we'll get to the nitty-gritties in a moment. But remember, this conversation is really to take stock of how we are doing in as far as preventing diagnosis and treatment and management of cancer in this country. And to help us along with this conversation, we have Dr. Sitna Mwanzi, who is an oncologist at the Aga Khan University Hospital. Also joining us is Christine Sitati, who is the CEO of the Kenya Network of Cancer Organizations, joining us virtually. We're also joined by Margaret Wanjiru Mburu, who is a breast cancer survivor, and she also is a caregiver. She'll tell us more about her story. And also joining us is Edgar Rodoli, who is a multiple myeloma cancer survivor. Now, some of you might be hearing this for the first time, but we'll delve deeper into that in a moment. And also joining us virtually, we have John Otanga, who is a leukemia survivor, still battling this disease, and he'll give us more of his details in as far as his journey is concerned. Well, before we get to that, let's give more perspective in as far as the effects of cancer in this country and how we are faring on. Now, last week, the Ministry of Health identified 5 types of cancers that are being responsible for half of the 42,000 cases reported annually. Now, to start with, women are most affected, with breast cancer being the most prevalent, followed by cervical, prostate, esophageal and colorectal cancer. Now, over the last 5 years, the World Health Organization estimates that around 82,620 people have been diagnosed with cancer in this country, and 66% of those are actually women. Now, early detection has been identified as the biggest challenge when it comes to cancer treatment, with 60% of breast cancer cases diagnosed in stage 3 and 4 when the cancer has spread to surrounding tissue and at least one other body organ. Now, only 16% of Kenyan women in the reproductive age group of between 15 to 49 have undergone cervical cancer screening, as you had the Ministry of Health lay out. Now, another statistic you need to keep in mind is that a cancer diagnostic test in this country at a public facility will cost you an average of 44,000 shillings and up to 132,000 shillings in a private facility. And even if cancer is diagnosed early, it will cost you between 147,000 and 1.2 million shillings in a private hospital for inpatient treatment of breast cancer, and in the first 2 stages per episode. Now, clearly you can see why some families go bankrupt when they are catering for their loved ones who are battling cancer. So let's understand how we are faring on and exactly how we can do better going forward. And I'll start off with you, Dr. Sitna. You are a member of the Kenya Society of Hematology and Oncology. You've been practicing for a while now. How are we doing as a country?
Thanks, Gladys, for having me on the show. So I would say that we are doing much better than we were doing before. There have been many things that have improved. I think one of the things that you talked about is about prevention. People cannot prevent something that they are not aware of. So increasing the levels of awareness is one of the key things. And I think that the ministry is working really hard to improve the levels of awareness, so that if you know about something, then you can actually go and access the prevention methods that we're talking about. The other things that have improved is the diagnostic capabilities. So things like having CT scanners, having increased number of doctors like pathologists who can actually look at the specimens and diagnose cancer, and then having the CT scans that can stage the disease. Also, we've seen the number of doctors taking care of cancer patients have increased. So before, most of us had to go for training outside the country. So now we are seeing that we have facilities to train oncologists in Kenya, which means that we can train a lot more people to be able to take care of the patients. Also, the availability of the treatments are more widely available. Before, you'd have to come to Nairobi for all your treatment. So I think now in terms of chemotherapy, you can get it in many of the level 5, level 6 hospitals. The only drawback is for radiotherapy, where most of the radiotherapy is actually in Nairobi, and now more recently at MTRH, Moi Teaching and Referral Hospital in Eldoret. The government has planned to have centers in Garissa and Mombasa, and I think in Meru for radiotherapy, which will basically increase the availability of this treatment, and people don't have to come to Nairobi to get their treatment. So there have been a lot of things that have improved, but we still have a long way to go.
And speaking about having a long way to go, we saw even the Ministry of Health highlighted that the cases of cervical cancer seem to be increasing, and so many women succumbing to cervical cancer. What's going on?
So I think it's amazing that that's happening, because if you look around the world, cervical cancer is not such a big problem, and that's because of, one, availability of vaccination, and number two, availability of screening. As you know, cervical cancer, 99.7% of all the cases will be because of a virus called the human papilloma virus, or commonly called the HPV, and there is an available vaccine that can prevent this cancer. Also, in addition, there is very easy ways of screening for the cancer, because it takes about 10 to 15 years after you get the virus for you to develop the cancer. So we have multiple opportunities to get the precancerous stages so that we can treat them before they develop into cancer. However, we talk a lot about breast cancer, but we don't talk a lot about cervical cancer, right? So one of the things is that just increasing the awareness about cervical cancer, making women more comfortable to go for screening, because it's a bit invasive. So many people are like, I don't want to go and, you know, have someone look at me down there. So we need to remove that notion that this is something that it's shameful, this is something that is invasive. It's actually a very simple process that can actually save very many women's lives. Yeah.
So are you saying a large extent is the fact that people are shy to even go for these screenings?
So the number one is awareness, knowing that that this problem exists, and what are the symptoms. Like if you have an abnormal bleeding, abnormal discharge, knowing that this is something that is preventable with a vaccine. So taking our children for vaccination, and knowing that screening can actually detect the problem before it actually becomes cancerous, and it can be treated. So there are a lot of things coming together that make many women not go for screening and testing.
And we'll delve deeper as to why people would rather not go for screening, and that gives a lot of, it informs a lot of these cases that are caught too late into their stages. Now, speaking of which, let's bring in Margaret, who has been a survivor of breast cancer over 20 years now. But before we get to hear her story, let's understand what breast cancer is, if we can have those graphics on the screen. Now, this is a cancer that forms in the cells of the breasts, and it is the most common type of cancer in Kenya and affects both men and women. Of course, it affects more women, but it affects both genders. Now, signs and symptoms in as far as breast cancer is concerned: a breast lump or thickening that feels different from the surrounding tissue, change in the size, shape, or appearance of a breast, changes to the skin over the breast, such as dimpling, a newly inverted nipple, peeling, scaling, crusting, or flaking of a pigmented area of skin surrounding the nipple or breast skin, and redness or pitting of the skin over your breast, like the skin of an orange. Let's hear from Margaret. Margaret, when were you diagnosed with breast cancer?
I was diagnosed in 1993, and I had a lump in my breast, I went to Kiambu Hospital where they did open biopsy. By then they were doing open biopsy. Then after open biopsy, I was told I have cancer and the breast has to be removed. So the Kiambu Hospital could not remove the breast. So I went to Nazareth Hospital where I met a doctor and he removed my breast. After diagnosis, it was only 23 days and he removed it, the lymph nodes. And then after a month, he gave me, after the wound, healing of the wound, he gave me chemotherapy 6 sessions. By then, we used to be admitted for a week so that he can see how you are doing with the chemo. And then after 21 days, then you come back. And after 6 sessions, I was referred to Kenyatta Hospital for more checkups, where I didn't have another cancer. So I was cleared. After 2 years, I was cleared cancer-free, and I went on with my work. When I was being treated during chemo, it was not so hard to me. I was in a hotel, so I used to go and manage my work, and then after 21 days, I go back. That didn't stop me from working, so I was on and off, on and off. And now I'm doing good, although I do go for checkups.
All right, so it has been 28 years since that initial diagnosis, and Margaret is a testament that a diagnosis with cancer is not a death sentence. Now, we touched on some of the symptoms that are associated to breast cancer. When you think back, what symptoms did you have? Margaret?
Pardon?
When you think back, what are the symptoms you had?
I had a lump in my left breast, and it was done open by the Kiambu Hospital. Didn't remove the breast. They only took some specimen. Where I went, I took to Kenyatta Hospital, and it was the doctor there at Kenyatta Hospital said I had cancer. Then back home, that's when the queue of Kenyatta, I decided to go to Nazareth Hospital, where they did mastectomy, removal of the breast, and then they gave me chemo. By then there was a doctor, he gave us chemo free. I didn't know about chemo, but he did counseling to us. As you know, chemo is not it's very hard to admit about chemo. If you feel you can't do chemo, because it's very painful, you get fatigue. So many, your hair, you lose your hair. So, and I admitted all those side effects.
Okay, and let me bring in now Christine from Kenco. Just listening to Margaret, I'm sure she's one of your champions in as far as ensuring everyone knows when you go for that scan and you get that diagnosis, it's not the end of the road. So how are we faring on when it comes to breast cancer?
Okay, thank you so much, Gladys, for having me here and for having this discussion take place. So right now, the data that is in shows that we are losing at least 7 women every day from breast cancer that are being actually diagnosed, and well, they end up losing their life. But again, as you say, breast cancer, cancer in general is not a death sentence, yeah? So there's what Dr. Sipna has alluded to, that indeed we do have some improved diagnostics in the country. But then again, from a civil society perspective, we need some improvement, especially to the community in terms of education. We need to ensure that the community members, public members, need to know the signs and symptoms. Margaret has talked of a lump in the breast. There are so many other symptoms that people may have. And what we have seen is that actually people, if you're not feeling pain, then you easily take for granted the other symptoms. And by the time you're presenting with pain or serious complications, then you're really in late stages. So we encourage people to actually go for screening. When you identify, get to know what is your normal kind of breast. For example, for breast cancer, how does your normal breast look like? Yeah, so that you can easily diagnose those abnormal things that come. the symptoms that you have mentioned. It is easy to recognize them, and then you need to go to the facility to have a health worker get to, like firm up the diagnosis for you.
And Dr. Sitner, there is the mammography that most specialists always insist on, especially after 40, is it?
Yes.
And how available are these services?
So currently the ministry has made it available that every county has mammography. And then also, that there's something called telehealth. You could have your mammogram one place and it can be reviewed at another place. So mammography is a simple X-ray for the breast. I think the important thing is having the right person looking at the mammogram so that you do not miss small lesions or miss other things like calcium inside the breast that could be indicators of cancer. So that's readily available.
And you insist that you should do this after 40, yet we're seeing younger and younger women getting breast cancer. So how now do we go around this?
So while it is true that we have younger and younger women getting breast cancer, majority of patients will be over the age of 40. Also, the use of mammography is kind of difficult in younger patients because they tend to have more dense breasts because they're in their reproductive age. So the breast at that point is geared to breastfeeding. So it has more glands, which on mammography might be difficult to pick small lumps or changes. So sometimes for younger patients, we use both mammography and ultrasound to make the diagnosis. So when you're looking at a population health, you're looking at where will I make the most gains. If majority of women will get breast cancer over the age of 40, then it makes sense from a public health perspective to start screening at that age. But as Christine said, do not ignore symptoms. People need to know how is my normal breast, so that if I get a change, even if I'm under the age of 40, then I go and see a health worker. So screening will not cover every patient, but it will cover the majority of patients. But knowing what to look out for, changes in the skin, changes in the nipple, a painless lump, swelling in the armpit, something that lasts for more than 2 weeks need to be checked by a health worker. Yeah.
Remember, breast cancer is the most common type of cancer in this country. Now, let's bring in the men in this conversation, starting off with Edgar Rodoli. He is a multiple myeloma cancer survivor. And if we can have those graphics on the screen to understand better what this cancer is about. Well, this is a cancer that forms in a type of white blood cell called a plasma cell. And the signs and symptoms associated with multiple myeloma are bone pain, especially in your spine or chest, nausea, constipation, loss of appetite, mental fogginess or confusion, fatigue, frequent infections, weight loss, weakness or numbness in your legs, and excessive thirst. Edgar, when we talk about these symptoms, what do you associate with?
Thank you for having me on your show. What I associate mostly is pain in the spine. In fact, before even I knew what was diagnosed for multiple myeloma, I didn't even know what multiple myeloma was. I went to the hospital and I went there for a backache. And the first time, that I just told the doctor that it's a backache, and the first thing I was done, I went for physiotherapy. But even after the physiotherapy, nothing was happening. So I was hospitalized and done thorough checking. And that's when the doctor said that I've got multiple myeloma. Like I said, I didn't even know what multiple myeloma, I had not even associated it with cancer. It's later on is when I came to learn that multiple myeloma is actually a bone cancer.
Okay, and how long ago was that?
That was 6 years ago. That was in 2014 when I was first diagnosed.
Okay, give us a snippet of your journey since, in terms of now you've told us diagnosis, the treatment plan up to now.
Okay, the treatment plan, I began off in Nairobi. I did it at Nairobi Hospital. So I went through my normal chemos and I went through my radiotherapy and all that. But then, and also on medication. But then in the process, I got a relapse. And I was recommended by my Kenyan doctor to go to India to do a stem cell transplant. Okay, at that time I was told it's not available in Kenya. So I got myself into India. spent a couple of months over there and did the stem cell transplant. That was in the year 2016. Then I came back to Kenya and continuing also on medication. And then at some point, again, I got a relapse. That was about like 2 years ago, that is in 2019. So right now I'm still on medication, recovered. That's the first relapse, and then the relapse that I got in 2019. And right now I'm on medication for the relapse.
Okay, when you say medication, is it just oral medication?
Yes, it is oral education and also transfusion through injection.
Okay. Now, when you think about your journey and you having to go to India, is it because these facilities were not available here or you preferred to leave the country?
At that time when I was going, I was made to understand the facility is not available in Kenya. And there were other options in Europe or South Africa, but India was the cheaper option.
Aha. Yes. I hear you. Now, Dr. Sitner, do we have these facilities in the country?
So we don't yet have a stem cell transplant facility in the country, and I think there are multiple reasons. It's very, it's a science that is quite intensive in terms of you need the personnel, you need equipment, and it's very expensive. But it is something that we are working on to have in the country, which will mean that people don't have to travel very far to get this treatment.
Yeah. Now, just looking at the symptoms associated with multiple myeloma, they look like symptoms of any other disease
even
out there, even a flu.
Yeah.
And in this case, Edgar says he went to hospital because he had an unbearable back pain. Does this increase the chances of misdiagnosis when it comes to this cancer?
Yes, I think that it does, because many people think of cancer as that you will have a symptom and the doctor will know straight away that you have cancer. Yet that's not true. It mimics other diseases quite commonly, because you could have back pain that is physiological back pain. You could have back pain because you had an injury. You can have back pain because you have an infection like TB in your spine. And then some of those symptoms are the same. You'd have fever, you'd have frequent infections, you'd have weight loss, which other diseases would have as well. So it's just someone having these symptoms and having the right person say, look, we need to do a lot more than just saying that you need physiotherapy, maybe do some blood tests, because multiple myeloma is something that we diagnose in doing blood tests and something called a bone marrow a biopsy. So looking for things like, do you have a high calcium, do you have, in the bone marrow we look at and say, do you have more plasma cells than you need to have. So this back pain is very common, yet it is the most common symptom for multiple myeloma and other diseases. So like you're right, it will lead to, it will take some time before someone is diagnosed with multiple myeloma.
Now, he talked about getting a stem cell transplant, and most people would think this is it. After this, I don't have to deal with this cancer, but he's had several relapses. Why?
Because a stem cell transplant is not curative. It is going to prevent, it will keep you without needing treatment for some time. Because he said he got the transplant in 2016 and then had a relapse in 2019. That's the aim of the transplant. So in multiple myeloma, it's more of a chronic disease that you keep needing to take medication on and off.
Okay. Yeah. All right. Now, Christine, this is one of those cancers, not very common, but it's still there. We have Edgar here speaking of the same. But then again, when you bring in the male perspective, how many of these men do we lose to cancer just because they never went to get that screening done in the first place?
Yes, that's a good question, Gladys. And it is something that is very prevalent in the community. We are finding men. It is a thing in men. I think probably their ego. They do not want to admit that they're not feeling well. It is very hard for a man to actually even go to hospital for just screening. Yeah. So in the community, with people like Margaret. Margaret is the director of Kiambu Cancer Support Group. And such groups who are under KENCO, we encourage them to go reach out to public members in the community. Tell people that actually cancer is there. They need to know the risk factors. They need to do the prevention bit of it and let them go for screening. For men, I think it is very African that the men are the family members, the leaders in the family. So they don't want to look weak. They don't want to look sick before their wives and their children. But now this is what is causing men then to succumb to cancers, and they would have gone to the facility in time. So we are encouraging our men please go to hospital. Number two, please talk about it. It is very common for women to talk about anything to any other woman, even if they are not, friends, or they are not, very good at their relationship. But for men, they really are good at keeping secrets. So get a trusted person, a trusted friend, a health worker, and go to the facility and get to discuss this. For health workers, we're encouraging for continuous sensitization so that they have the high suspicion index. When that man presents in the facility, when that woman presents, please get to suspect some signs for cancer. Just like Dr. Sitna said, some may be covered up in so many other symptoms that may be for other diseases.
All right, let's bring in the other gentleman in this conversation, my former colleague John Otanga, who is a leukemia survivor and also still battling this condition. Before we get to hear his journey, let's take a look at what constitutes leukemia. Now, the signs and symptoms of this disease, if we can have that. First of all, it's the cancer of the blood, of the body's blood-forming tissues, including the bone marrow and the lymphatic system. The symptoms associated with this, and okay, fine. Before that, with leukemia, the bone marrow produces an excessive amount of abnormal white blood cells which don't function properly. Remember, the white blood cells are the good soldiers that keep your body safe from disease. Now, there are many types of leukemia, some common in children and, of course, others in adults. The symptoms vary from, one type of leukemia to another because there are several, but the common types or signs and symptoms are fever or chills, persistent fatigue, weakness, frequent or severe infections, losing weight without trying, and swollen lymph nodes, enlarged liver or spleen. Also, easy bleeding or bruising, recurrent nosebleeds, tiny red spots in your skin, and excessive sweating, especially at night. John, it's been a while since you were diagnosed. How long ago was this?
It is around, thank you, it's around 10 years back. Huh? I was diagnosed in 2010. Yeah, after a very long search, because I didn't know what was happening with my body, because I just lost weight. I used to be a very big guy. I used to work out. But now I just lost weight. Basically, after let's say three months, I'd lost around 22 kgs. Now I had to go around the hospital to see what's going on with my body, because I didn't know I could be having such a disease. I started by going to a public hospital where they said I was having ulcers. Then they prescribed for me painkillers and some antibiotics and the ulcer medicine. So nothing happened to me. The condition just continued, losing weight, getting weak. We say the signs of leukemia, sweating at night, and losing weight and having an enlarged spleen was very difficult to me, and also pain in my joints. That's when I went to I picked an opinion from another hospital. When they checked my blood, they saw there was imbalance in my blood. The white blood cells had gone very high. They had gone up to around 400. So that's when the journey started.
Okay, and when exactly did you start the treatment plan?
Before you start a treatment, you have to undergo a lot of tests. Going around shopping for places maybe you could find you could be tested. So the treatment started basically in 2012. That's 3 years after the diagnosis. So I went to the public hospital where they checked my bone marrow, and by then had dried up because when they were trying to get the bone marrow from my chest, it was not able to get out. So I had to go for another one at the Gachanja. So my journey started at Gachanja, where I was given some oral drugs to start the treatment.
All right. And there was a time there where you looked stable. Your weight came back. You were going about your business as usual. What now led to the relapse?
You see, I don't know what happened, but my body started developing resistance to the then drug. Yeah, and then my doctor, I suggested to change my doctor. I went to Nairobi Hospital to another hematologist. That's when they changed the drug. After a while, it developed again resistance. I've changed drugs now for the fourth time, different drugs. Now, since last year, I developed another resistance. After taking the drug for like 3 weeks, I started getting very weak. My spleen enlarged again. I developed the same pains that I got, but this time was very severe. I was sweating excessively at night. I could sweat for like continuously 3 hours, seated sweating. That's when I went to the doctor. He suggested for a blood transfusion since the blood levels had gone very, very low. Yeah, when I was admitted for blood transfusion. That was in December, late December. I got transfusion for like 3 pints and my platelets were even low. I got even transfusion for the platelets for like 4 pints. This is when I'm trying to stabilize the new drugs. I hope they won't develop resistance again. But for now, since the doctor told me it will be maybe the last medication for this condition. The next time when the drugs when I develop resistance, it will force me to have inducement of chemo for some sessions.
Okay, now you have been raising finances or monies to actually go for further treatment in India. What is this that the doctor is saying you will be provided for in that country to help you along?
Yeah, the doctor, because I need to go to India, since my worry is the resistance, the body resisting the treatment. But now going to India, I need to raise some funds, like 4 million, because I'm supposed to be in India for 4 months. Now the doctor in India is saying I'll have to get several chemo to kill the current cells, so that they could, after getting a donor, so that they could plant new cells, fresh ones in my body when I go there.
Okay.
So after the chemo sessions that will last for around 8 weeks, as per the doctor, I'll have to get new cells, the new blood planted in me, the bone marrow.
Okay.
So for now, I'm still raising the funds. Sorry.
All right, and we'll talk more about that in a moment. It has been quite a journey, as you can hear, that John is actually not feeling too well. He's very weak, and for us who've worked with him, we've seen him go through this journey. The question is, he wants to go to India to get the bone marrow transplant. Are we also saying we don't have the facility to do so in this country?
Right. We don't have the facility to do the stem cell transplant.
So it's the same thing, bone marrow, stem cell, same thing.
Yeah. So I think the idea in some of these blood cancers is you want to clear out all the the cancerous cells. And then if you clear them out, it means that your bone marrow is not able to produce the white cells that protect you from infections, the red cells that carry the hemoglobin, and the platelets that prevent you from bleeding. So you want to clear the bone marrow of the cancerous cells and then get other cells from a donor to transplant, and those cells which don't have cancer now become like your normal cells. So the process is that he has to get chemotherapy, like he said, to clear out everything and then get a transplant. And there are different types of transplants. There are transplants where your own cells are used to transplant, and the other one is where you're getting a donor, someone else giving you their cells. So there's an autologous transplant where the cells are from you, which is what many myeloma patients will get. But then you have the allogeneic transplant, which is from someone else who has to be matched to your type of cell. And that one is a more intensive kind of transplant and mainly used for leukemia patients. Yeah.
So have you seen, from your experience, have you seen leukemia patients get the intervention they need and actually live a long life? Yes.
I mean, there are patients who've gotten transplants and are fine now, but the treatment itself also has risks. It's not just that it's a simple process. It's a very complicated process. People get infections. As you can imagine, you have nothing to protect you from infections, and some people die during their treatments. But for the people who actually are transplanted and they go through it, then, and we're talking about now the allogeneic transplant where you're getting cells from someone else, then most people are able to survive. And they just need to be on follow-up because there are other complications of the transplant themselves. Yeah.
Okay, and speaking of infrastructure supporting the cancer diagnosis and treatment in this country, access to quality healthcare has long been a painful journey for thousands of patients battling cancer, and I'm sure you've had a lot of this in this conversation. Now, a cancer center with a chemotherapy unit with a capacity to accommodate up to 40 patients a day has been opened in Nairobi's Upper Hill. Now, the facility is set to inject hope to those fighting the disease who often have to travel to countries such as India to access the relevant healthcare. Eunice Omolo with more.
More cancer patients are estimated to have been adversely affected in Kenya due to the COVID-19 pandemic. Global airspace shutdowns affected movement abroad for patients who needed treatment outside the country. The cancer treatment facility is said to be part of the improvement of cancer management and treatment in Kenya and can accommodate up to 40 patients a day.
The center is able to treat patients at a considerably lower cost than those who travel all the way to India. Because you know when you travel to India, there's a question of transport, hotel, and normally you have to be accompanied by a relative.
The limited facilities and the high cost of treatment has led many Kenyans to look east for cancer treatment and care, especially in India.
We wanted to give our patients a location which is totally free of feeling that you're going to a hospital. Well, we can look at something like on an average 300 to 400 chemos a month from this facility.
The annual incidence of cancer in Kenya is about 28,000 new cases, with an annual mortality of around 22,000 cases. That is, 78.5% of the victims do not survive. Cancer is also said to be the third leading cause of death in Kenya, after infectious diseases and cardiovascular diseases. The launch of the Cancer Center is set to give a facelift for specialized cancer treatment in the country. Eunice Omolo, NTV.
Before we get to the nitty-gritties, more of it at least in as far as treatment is concerned, we are asking you the question of the day today. If you do know somebody who is battling cancer or someone who has succumbed to cancer, let's send a message of hope and condolences using that hashtag new normal, because cancer is a reality in this country. Kevin Makolola says, when I hear the word cancer, I do remember my late mother. Cancer, cancer, cancer. Rest well, Mary Nyar Kager. May she rest in peace. Adrienne Susan says, yes, I have, and it's the worst experience ever. Up to now, I have never been able to call her, but always in my prayers. I will start crying again, so God gives me the strength. I hear you, Susan. Ron's Cheer says, we lost our mom to cancer. Poleni sana. Another one here from Joroge Wakamau who says, I have come across many. Some have died, some still battling the disease. It's painful, finance draining, and leaves the family in a poor state. May Almighty God intervene. However, prayer needs to be facilitated by some kind of efforts, which the government of Kenya is not ready to incur at any cost. Thus, poor Kenyans are dying every day like dogs. Joroge continues to say, all officials in the government, God is watching all those billions getting lost each year, and every day can save lives, not single politicians, is for the poor. My message is to the government, equip all hospitals to a capacity they can handle cancer patients and provide free services to them because it is possible. We hear you. And a last one here for now. We have Royal Shea who says, I lost my grandfather and my uncle to prostate cancer and my friend to throat cancer. Thank you for sharing, and may they all rest in peace. We'll continue taking more of your condolence messages and experiences in as far as cancer is concerned. We are about to take another short break here, and when we come back, we'll talk more about the challenges of treatment in this country when it comes to cancer. Stay with us.
We are Nation, Africa's independent media brand. We are committed to empowering all Africans, from the young to the old, from the curious to the educated, and from the heart of the cities to the rural areas. We are Nation. Join us, because if you want to get far, you do it together. Nation. Empower Africa.
Credo Mix is all about anything created artistically by us, for us. Music reviews. Feel the fresh vibes, full of surprises as we get interactive with your favorite artists and celebrities exclusively. We will bring you all the latest hits, trending topics, and the weekly top 10 every weekday from 5 to 6.
And you're watching Credo Mix on NTV. Keep it locked.
Why did you start telling everybody about my own problems? Do you realize what you've done?
But it's not like that. I just did it because I was really worried.
We had a fight and I resigned.
I don't understand what you mean.
Every day it's getting harder and harder to contain my emotions. But I still have to stay and make sure that the land has been secured.
I forbid you from giving my daughter's things away. Do you understand me?
You and I are not in the position to decide what to do with her things, because the only ones who can make that decision are my children.
No!
Along came love.
Try Panadol Advance for relief from headaches, body aches, and fever. With Panadol's Optizorb formula, the tablet gently breaks down in the stomach, quickly absorbs, and starts providing pain relief in 15 minutes. For fast and effective pain relief that you can trust, try Panadol Advance.
Thank you for staying with Your World. My name is Gladys Gachanja. This morning we're having a cancer dialogue, just understanding better how we are faring on as a country in as far as prevention, diagnosis, treatment and management of cancer is concerned. And helping us along with this conversation, still with me in studio, Dr. Sitner, who is an oncologist at the Aga Khan University Hospital. We are also joined by Christine Sitati, who is the CEO at Kenko. And we have survivors. That is Margaret, who is a breast cancer survivor. We have John Otanga, who is a leukemia survivor, and we have Edgar, who is a multiple myeloma survivor. Thank you all for staying on this conversation. Now, our conversation, or rather question of the day to you has been, do you know somebody who is battling cancer or who has succumbed to cancer? And we're giving you the opportunity to send a message of condolences and also share your experience in as far as walking with them this journey is concerned. And speaking of which, we all know there are people who have succumbed, and we would like to remember them as we speak more about the Cancer Prevention Awareness Month. Take a look.
Binadamu ni mavumbi, mavumbini atarudi. Binadamu ni mavumbi, mavumbini atarudi. Na tukifika huko, tutaimba haleluya. Makao ya raha.
Put it out there. This is just a drop in the ocean in as far as those we've lost to cancer in this country and the world over. So we just took time to compile some few names. That's why we're giving you the opportunity to share with us those that you know that have passed on due to cancer and those that are battling this ravaging disease. Remember that hashtag is new normal, and you can also call us using those numbers at the bottom of your screen. So let's talk about the challenges of accessing treatment in this country. I'll start off with you, Margaret. Wewe umekuwa survivor 28 years now, and you started off your treatment when most people did not even understand what cancer was about. Nani alikusaidia na finances?
Mara ya kwanza nilisaidiwa na jamii. Hakukuwa na pesa nyingi, ilikuwa only 5,000, but by then 5,000 was a lot of money. I was very lucky for the first, in that 1993, because Dr. Bill, who is now at St. Mary's Gilgil, he assisted me with chemotherapy and some other drugs which I was taking after chemotherapy. So I didn't struggle for the first time. But you know, cancer is not, it can come back. It came back in 2013. Mm-hmm. There I had a lot of struggle. I struggled to get money for treatment, and yet then I was to be given adjuvant chemotherapy, which was about 800,000. I didn't have even a penny, but lucky enough, I was assisted by Faraja Faraja Trust. Mm-hmm. They gave me some money, and I was treated. And some other friends gave me some money. The challenge is, in government hospitals, you don't get those drugs. And even if you get them, you have to wait, and you know the disease is not waiting. It's still going on, growing in your body. You are becoming weak. You are stressed by the stress of cancer. You know, cancer is not it's not a good disease. Let's call it bad. And still I managed with the help of the community and Faraja Cancer Trust.
Okay, so are you saying in those 28 years, you've never had support from the National Health Insurance Fund?
No, I didn't get for treatment. Mm-hmm. But later on, after treatment, for the second time, I was given tamoxifen, and I was not to be given tamoxifen. I had to take retrozole. So the tamoxifen raised arthritis, and I had a gap in my right leg, so I had to go for treatment at Consolata Mary Immaculate huko Nyeri. That's when the NHIF helped me with the NINI to be put upright in my right leg.
So all the chemotherapy and all the drugs you've had to take him through the years, you've never gotten any support from NHIF?
I didn't get any help from NHIF.
All right. Let's hear from Edgar. Have you had support from the NHIF?
Yes, I have had support from the NHIF, but I can't say it is on a positive perspective. What I feel is like I was held at ransom with them. When I went, you know, I used to pay my monthly premiums, okay? And then when COVID came, you know, we were put out of work. And so it's like the NHIF did a background check, and so that the income is not coming in as it is supposed to be. So what they did, they actually made us pay our premiums. This is in 2020 when COVID came in. They made us pay our premiums upfront for 2 years. This is in 2020, so they made us pay our premiums up to December 2022. And it was a leave it or take it. They were not mincing words. Yes, okay, I agree they pay, but we were caught off track. And then they have a ceiling. They have a ceiling cutoff. Whatever expenses you go to, they can only fund you up to 20,500 maximum. I'm talking of a treatment. Like, for example, I'll give you a breakdown of some of the treatment I take. I'm on medication of some oral drugs called palomidomide and dexamethasone, which actually cost 40,000. These drugs, you take them for a span of 21 days. Then after 21 days, you take a 7-day break. In layman's language, what I'm saying here is that after 21 days, you are supposed to come up with 40,000 shillings, whether you like it or not, to continue your medication. That is not easy. And then there is another whole array of medicines that comes after that have to be taken monthly and also after 3 months. And now we are talking of a total of 126,000 shillings that you have to come up with in 3 months. Out of all this, NHIF is only giving you 20,500. Okay, something is better than nothing, but I believe the NHIF can do better than that. With the amount of money that is being stolen in this country, it should be pumped into the health sector.
We hear you, Edgar, and definitely agree with you. Now, have you ever had support from a private health insurance?
Yes, I used to have a private health insurance, but they're not any better when it comes to cancer. Truth be told, they just operate like cowboys. As soon as, you know, when you're in the scheme, on the insurance scheme, or they'll treat you well, and you think everything is hunky-dory, until you go to renew your insurance, you know how you renew it annually. That's when they open up some fine print from I don't know where, and they tell you, okay, now that you've discovered that you're a liability, we are not taking anything away, any money from you, and they put you away, I mean, they stay away from you with a 10-foot pole, and you're left on your own. And now those expenses, you have to think of where you're going to the finances from, and you have to dig into your own savings and to your extended family and to your friends, which is a burden. So I wouldn't say insurance companies are any better when it comes to chronic diseases.
Okay, John, definitely you have been raising funds to go for further treatment. With the treatment that you have been going through in the 10 years, did you get any support from NHIF or any insurance company?
No, I didn't get any support from any insurance. But the treatment was not that a burden. But where we go, the problem was in the tests that you take. You undergo a lot of tests back and forth. It's very expensive test to undertake. But the treatment itself was somehow reasonable for this condition. But you see, at this point, the drugs that I've been using have become resistant. Now I have a burden of going to overseas for the transplant, because now, as the doctor said, my consultant told me this could be the last medication that I'll be taking. The next one will be chemotherapy, which will be very expensive in the country. So I have to seek treatment from India, maybe, because for now, if when the drug resist, for now, I'll have to go for chemotherapy in the country. But for now, if I get the funds, because I need the funds as soon as possible to go to India, because for now I'm a little bit weak. I'm not that strong to move around and to work, and the NHIS is not supportive, and I don't have any cover. So I need the intervention of my friends and relatives to come and support me in this journey.
Okay, now John Otanga's story is the story of many others, as you've had from Margaret and Edgar. Christine, just listening to this, we know that cancer literally is a race against time. The more you wait, the more you actually have severe disease. Why are we seeing NHIF not standing with Kenyans when it comes to cancer?
Thank you, Gladys, for that question. It is a serious concern that we are currently having as a KEMCO. Just like what John has said and Edgar, yes, NHIF does cover a part of the oncology package, but we have maximums when it comes to the various treatment modalities. A patient, depending with the type of cancer and the severity of the cancer, each patient will have different sessions, for example, for chemo or for radio. So when you put a maximum on those sessions, or you have a ceiling amount, or what Edgar says you're told to pay upfront for 2 years, then it means you're really stressing up that patient. They will take what NHIF has given, but at some point in time, they will drop off from treatment, which is really hard and sad, because again, cancer will not wait. It is progressing. It needs immediate treatment. The other thing we tend to forget is that this patient actually has other hidden costs that they have to consider. Their transport costs to move from their home to the chemo centers or to the radiation center. And remember, for example, we've only been having KNH with chemo, with radio for a very long time, until recently when MHRH launched this. So the transport costs, the food costs, the accommodation costs, both for the patient and for their caregiver, these are very expensive. Margaret said she would go to her workplace every 21 days. So it means for some employers, they will not tolerate that. They discriminate the patient and the patient loses their job. Or even if it is self-employment, then you're not able to open up your business. So this means then you're only depending on NHIF. Then it comes and frustrates you. And this is what we are saying as a national umbrella body. It is high time that the National Health Insurance Fund had a serious discussion on a comprehensive cancer care package. And it will not be done in boardrooms. We need to have the conversation with the patients, with the cancer survivors who've been through this, who are undergoing this, for them to be able to have a concrete discussion on how this plan needs to be like. So that is our call on this. Otherwise, we are affecting treatment. Patients have presented themselves. They need to be treated. Doctors' hands are tied. They will not do the treatment if the patient lacks the money. So it is a genuine concern for us, and we need to have this conversation, Gladys.
Okay, now, Dr. Sidner, just earlier on I mentioned how much it would cost you to even do the diagnostic test in a public facility and private facility, and whichever way it is beyond many Kenyans. Having experienced and even seen how systems work in other countries, what is this that they have in place that perhaps if we borrowed, all Kenyans of all walks of life would have access to treatment at their doorstep?
I think it starts with how much of our national budget do we give to health. And then because there are some guidelines that like the WHO say you need to put 15% of your national budget to health. And I think we are about 7%. So it means that our total health budget is lower than what we need it to be. And then also understanding that despite having that amount, there are other competing health interests. there is not just cancer. There are patients, you said, infectious diseases, cardiovascular diseases. Then we are talking about cancer. You have increasing numbers of diabetes. You know, so everything is increasing, but our health budget is not increasing. And even if it is there, then how are we allocating these resources to, you know, to these things that are needed? So we have to prioritize what is important. I think countries like the UK, which has the national NHS, National Health Service, where I trained, all cancer patients get their treatment for free. As soon as you're diagnosed with cancer, your diagnostic tests, your treatments, everything else is covered by the government. So that's a system where your taxes actually work for you. You don't feel paying for the taxes because you know that if I'm sick, my country is going to take care of you. And different countries have different models. A lot of our healthcare is personal driven, that if I'm sick, then a majority of the cost will come to me as an individual. And like you said, this is way beyond what normal, you know, Kenyans can afford. So, you know, in theory, things like universal health coverage are supposed to take care of that, you know, making sure that health is available equally and without causing financial burden to everyone. But are we really moving in that direction? You know, like we talk about UHC, we want to implement it, but we're not seeing the benefits of it on the ground. Yeah.
Okay, and what I don't understand is they would cover a bit of the treatment, but not even touch the diagnostics. Yet we are telling Kenyans to go for screening. How can even those stakeholders in this space help out in giving Kenyans a chance at least to do screening?
So NHIF covers for part of the, it doesn't cover for screening, but covers for part of the diagnostics. Like once you're diagnosed with cancer, it pays part of the cost for like a CT scan or MRI. It doesn't pay for it in full, but it does pay for part of it. So obviously there are challenges in any model for healthcare financing. So we have to look at what is it that will work for us. Like one of the survivors said, even your normal insurance will have some limitations as to what they're going to pay for. So eventually, most patients pay for their care themselves out of pocket.
There has been a mention of lack of drugs, like you have a prescription, you have the money, but the drugs are not available. Margaret, is this something that you see, especially amongst your support group?
Oh, yes. Like we do home visits in our support group, and this makes even you sick, and you are not feeling as if you are normal. I went to a home visit where I met a lady. She could not get treatment because of money, and the breast was rotten. She didn't know whether Kiambu Hospital has pain management, so she stayed at home. You could not enter that house because of the smell. She don't have drugs. She don't know where to go. She has no information until a friend came to us, and we visited the lady. And now, I think she went yesterday to see our palliative care nurse, and that makes you feel as if you are not in your place, as if you are not, well, I don't know how to explain it, but you feel it.
Okay, now Christine, just listening to everyone talk about the burden of accessing treatment. Clearly, it looks like if you are poor in this country and cannot pay for your treatment, you literally have been sentenced to death. What are you doing as Kenko and other stakeholders to ensure that the government keeps up or pulls up its socks, so to speak?
Okay, remember Gladys, it is a patient right to get the right treatment, to get affordable treatment, to get treatment that has, of quality. So this is a patient right. And as an advocacy organization, we are really discussing with the right stakeholders. We are involving the National Cancer Control Program, the National Cancer Institute, for us to have these discussions on health financing and very many other things. For example, on access to medication, on access to other commodities that cancer patients will need for survivorship. For example, they do need things like breast prostheses. People who've gone through surgeries like Margaret, they will need stoma bags, they will need compression stockings. Then we need to make this available to those survivors or to those patients. So we are having those continuous advocacy sessions with government. We are also doing a lot of advocacy when it comes to the national budget. Every year, Treasury will always do a public call for participation in the national budget. And like now, they have released part of what the budget will look like in the next financial year. So as an advocacy body, we get to discuss with the patients and the survivors, what do we need included in those budgets? Yeah, so that we have money that is actually set aside for non-communicable diseases. For a long time, we have noted that more money goes to communicable diseases. But remember again now, non-communicable diseases are on the increase, and it means then we need more money to be able to take care of the issues under non-communicable diseases control. For example, prevention will need money, treatment will need money. You know, survivorship in itself, there are programs that need to run and they all need resources. So we are doing a lot of advocacy for that. We are also sensitizing people on the community. They need to know their rights. They need to ask government for these services. Yeah, because it is not very fair. We have very many people who earn below $1 every day. And the costs that you are mentioning, it is really expensive, Gladys.
Okay, now let's hear from the survivors themselves. John, I'll start with you. What do you expect the government to put in place to make this journey a little bit easier for you?
Yeah, on my side, you see, as Christina said, we need to have the government concentrating so much on these non-communicable diseases. That's right, because as much as we see the government officials dying, MPs and even governors dying with cancer, not the government is just they just rally in the funerals and saying they'll do something for cancer patients, they'll do something for cancer, but nothing so far has been done. I think the government should walk their talk, because cancer treatment is not easy. And okay, so far it's not a death sentence, but you see, when the government is not supporting, it becomes a burden, a heavy burden to the family, friends, and even the patient. You see, when you are not settled in your mind as a patient, you can't get treatment. You can't get healed. The process becomes very difficult for you to heal, because you think of how you can raise funds, where you can get drugs, where you can get support. At the same time, you want to get well. So it becomes very easy for the process of healing for the patient. So I think the government should consider the NCD, not first, but among the agendas and everything they think of, and the budget for the patient. Because for now, cancer is becoming a menace in this country. People are dying in silence. People don't get diagnosed. When you get diagnosed, maybe it's too late. You can't get even treatment. The cancer is already spread in the body. So we need something on diagnosing and the testing. The government support the patient.
Mm-hmm. Okay, Edgar, you've walked this for a while now, and thankfully you've had support system that has seen you through it. But if you were given an opportunity to speak to the head of state today, what would you tell him?
I'll tell him in his face he has got to wake up and put things in order without mincing words. Because it is typical of Kenyans in this country, we let things happen the way they are because we can't stand up. We look at leaders like the president and the whole entourage of leaders in this country as demigods. We should stop thinking like that. They should be told what exactly is happening. I'll give an example. When I came back from India in 2016, the Prime Minister of India came on a visit to Kenya, and he met President Uhuru Kenyatta. And in their conversation, they struck a deal where President Uhuru Kenyatta said a lot of Kenyans go to India for treatment in hospitals in India. And he said Kenya was prepared to give land in Kenya so that they can come and build cancer hospitals in Kenya. That was in 2016. Then it just went under the water. That shows that there is no sense of, of taking care of sick people. So if I had an opportunity to meet him one-on-one, I would tell him in his face, people are dying and you have to do something. You're not a leader there for nothing. Because we are dying in the doldrums. And all you and other leaders can do is come to our funerals and throw theatrics.
All right. And Margaret, you have been a survivor 28 years. You walk with a multitude of other survivors. What would you tell the government or even the county government to do to alleviate the pain and the misery that comes with the diagnosis?
Well, me, I would say they come to the ground and see how people are suffering from cancer. Those who have not gone to the hospital, they had no money, so they went home, they stayed there. No help, no food, no what. So they come to the ground and see what is happening in the ground.
Okay. And there is those who now, as we've heard, NHIF is asking that you have to be a constant contributor. You have to pay 2 years up front. Many Kenyans cannot afford this. How is poverty making this situation worse?
It's going to be worse even more, because if you tell are ready to pay for about a year, that is about 6,000. She can't afford. Even food she's not affording to buy. So they can do something else, like equipping government hospitals with some cancer drugs or cancer treatments, especially at the county's level. And also they train oncology nurses on how to help us when we are, for the first time you have to meet a nurse. Not even a clinical officer, a nurse. And that nurse doesn't know anything. So I can even tell the government to train more oncology nurses to be helping the people at the ground.
Okay, yes. And definitely this can be achieved now that health is a devolved unit. Dr. Sitner, we don't have enough personnel, very few oncologists, but we can actually drum up support for the same. How would be an ideal situation? What's an ideal situation with the counties in effect?
You mean for cancer?
Yes.
Yeah, I think it starts at the primary level, as one of the survivors is saying, is that the healthcare workers also need training so that they can identify that there is a possibility of cancer. So from the primary healthcare level, if Margaret has gone with a breast lump, she's told that I think this is cancer and referred to a place where she can actually get a biopsy and a mammogram done. So it starts at the primary healthcare level, having the trained personnel to say, this is what I think could be. And then having at least the level 3 level to have diagnostic capability so that people don't have to travel far. They can, within a 100-kilometer radius, they can actually go to a place where they can have a test done and the confirmation is done. And even if the specialized treatment is not available in that setting, at least within the county, there is a place where they can go and get treatment and they don't have to travel all the way to Nairobi or to Eldoret or to other major centers. So it's starting at the primary level in terms of educating the healthcare workers, raising awareness within the community that this is something that that cancer is a true disease, and these are just people being aware of the possible signs and symptoms, and an initial place where they can go and told this is something that's you're likely having, a referral center that's not very far from them, and a treatment facility within the county that can offer the specialized treatment. Of course, we have to treat our healthcare workers well. We know that there are healthcare workers who are still on strike because of payment. So, I mean, we need to resolve issues like the healthcare worker, strike. And even when counties are given budgets, I mean, they're given funding for their counties, that part of that funding goes to health. Yeah.
All right. When we come back, definitely research is also very critical when it comes to the prevention of cancer, but also what else can you do on a personal level to ensure that we also keep those numbers of cancer at a minimum? When we come back, that and much more. Stay with us.
Tutaimba haleluya, makao ya raha na starehe iko uko mbinguni. Binadamu ni mavumbi, mavumbini atarudi. Binadamu ni mavumbi, mavumbini atarudi. Na tukifika huko tutaimba haleluya.
Maji mdosi wangu ametupa simu yangu ndani ya maji.
Mdosi wako kwa sawa? Venye Nkirota ameniambia ajui na akimpigia simu ashiki. Hi! Guy! What the?
For the women who deserve more, Moped is now in Kenya and more than 40 countries. With its nylon-free surface, new Moped has unique softness and up to 100% protection. Your skin will love it.
Breaking news from Molfix. Let's see what they're developing right now.
Molfix pants with anatomic fit technology. New Molfix pants, an invention from babies for babies.
You should also try Molfix.
New Year comes with New Year deals. Renew your corporate subscription and get a bonus. Subscribe to Nation e-paper for 3 months and get 1 week absolutely free. 6 months and get 2 weeks absolutely free. 1 year and get 3 weeks absolutely free. To sign up, visit epaper.nationmedia.com or email subscription@ke.nationmedia.com. Offer valid till 28th February 2021.
Credo Mix is all about anything created artistically by us, for us. Music reviews. Feel the fresh vibes, full of surprises as we get interactive with your favorite artists and celebrities exclusively. We will bring you all the latest hits, trending topics, and the weekly top 10 every weekday from 5 to 6.
And you're watching Credo Mix on NTV. Keep it locked.
This is the EcoMed oxygen plant in Johannesburg, and as soon as they come in, these cylinders are being refilled. And since the beginning of the second wave of infections in December, the plant has been running 24-hour shifts just to keep up with demand.
My name is Ali Omar, popularly known as Ali Lamu. I have been a fisherman for 18 years. Currently, I use the sailcloth to make bags, and that is my business.
Heaviness and a burning inside, it could be heartburn.
Indigestion and heartburn? Eno gets to work in 6 seconds and works on the 6 symptoms of heartburn so you can keep living life non-stop. Eno, fight heartburn and indigestion fast.
Try Panadol Advance for relief from headaches, body aches, and fever. With Panadol's Optizorb formula, the tablet gently breaks down in the stomach, quickly absorbs, and starts providing pain relief in 15 minutes. For fast and effective pain relief that you can trust, try Panadol Advance.
Thank you for staying with Your World. My name is Gladys Gachanja. Today we're having a cancer dialogue, even as we take stock in as far as how we're doing as a country to manage cancer. Now, before we get back to that conversation, let's take a look at the other world. Now, Emirates Airline says it would make daily deliveries of coronavirus vaccines to countries with low storage capacities, as part of an initiative to accelerate global jab distribution. The Dubai-based company, the Middle East's largest carrier, will use both its cargo and passenger fleets to deliver vaccines to countries without the means to stockpile vaccines. The deputy head of Emirates Cargo Division says the majority of these countries have storage problems, while we have the capacity, adding that the initiative involves most developing countries in the Middle East, Africa, and the Indian subcontinent. And still on the pandemic, a team of 26 nurses and medical equipment sent from Germany arrives in Portugal, where hospitals are overwhelmed by the surge of coronavirus cases. The military plane carrying 8 doctors and qualified medical staff, as well as 50 ventilators, 150 IV machines and 150 medical beds, landed at the Lisbon airport.
The medical support team consists of 8 doctors and 18 nurses that are due to work side by side with Portuguese doctors and nurses in a Lisbon hospital, Hospital da Luz, fighting the corona epidemic. They will bring with them substantial medical equipment.
Elsewhere, the chief of the Pakistan state of Singh says he is thankful after Pakistan begins inoculating healthcare workers with the Sinopharm vaccines gifted by Beijing. Now, China has donated about 500,000 doses of their Sinopharm vaccine, which has yet to be fully approved by its own health authorities, with a further million expected by the end of the month. Pakistan will begin administering a Chinese-made COVID-19 vaccine to frontline health workers Wednesday, but the country is still months away from a mass rollout. The country of 220 million has recorded more than 500,000 coronavirus cases, with around 11,000 deaths, but limited testing suggests true figures are likely much higher. Back to our conversation of the day, and remember that question is, do you know anyone battling cancer or someone who has succumbed to the same? Let us know, and also send a message of condolence to those who lost their loved ones to this disease. Be Real says, my dad never told us he was sick until 1 week before he faced his death. Wow, Poleni Sana. Sisa Ian says, valid point raised by Christine. Men have a worrying health-seeking behavior. Not until the pain has become unbearable will men see a doctor. Encourage men to seek healthcare. True. Sarangiga says, I lost my best friend to breast cancer last year on the 1st of December. Her journey was very painful until her demise. It broke me. Cancer may have started the fight, but we will be the ones to end it. Amen to that. And Polesana Sarah. Elio Pio says, the issue of cancer has now become rampant. It is true. And I think at this point, it will be important to ask Dr. Sidner, why do we have more cancer cases today than before?
I think there are multiple reasons. The first one being that we have more diagnostic centers, so people are actually going and getting diagnosed with cancer, and we're recording it. So it's likely that people may have died of the disease without us knowing it before. Also, because we've changed how we live, so the risk factors for cancer have increased in our population. We have more people smoking, we have more people who are obese, we have more people not exercising, and then also we have virus-related cancers in our country. So we've talked about HPV, leading to cervical cancer. Then there is hepatitis B and C that lead to liver cancer. And then we have some of the HIV-associated cancers such as Kaposi sarcoma and lymphoma. So if we have a high burden of these infection-related cancers, then we know that a high burden of these infections, then the rates of cancer from these virus-related cancers will increase. So there are increase in risk factors that are leading to cancers, and then we have infections that lead to cancer, and then also just people now going and getting diagnosed.
All right, yeah. Edgar, there is that point about men's health-seeking behavior being terrible. I mean, there is a family that says he never said he was sick and perhaps did not know until very close to his death. What would be your message of advice to the men, especially when it comes to seeking medical advice?
Men should know that life has changed. This idea of pretending to be Mr. Tough Guy, you're the strong guy, and you know there's always that thing, it'll go away. This is just a pain, it's just a state, and after some time it's going to go away. No, that is a very wrong thinking. I think, like the doctor has said, the sickness does not have any, it's not gender sensitive. The way it attacks women is the same it will attack men, and men have to seek, because there's no harm in it. You see, the stigmatization is more stronger in men because it pulls down your ego as being, a small guy, you're weak, and every man wants to look tough. But in sickness, when the sickness comes, it is going to make you weak if you don't come out and speak, or if you don't come out and seek medical attention. So the bottom line is that you're going to be weak, which you don't want to. So the best thing is to seek medical advice as soon as possible, so that the medical fraternity can take care of you. And the chances are high that if you seek the medical attention early, then the possibility of you being strong or even the cancer going away. And you know, you'll save everybody a lot of hullabaloo and take off this mindset that men have that they're the tough guy. Get out of that tough guy cocoon and know that you're human. You need medical assistance. You're not Superman.
Aha. I'm glad that this is coming from a guy to fellow men. Now, if there's one other thing that stands and walks with those that are living this reality, is a support system. Very crucial. But this same support system, even as Edgar has mentioned, this stigma can actually accelerate disease because you just cannot handle the circumstances you have to live in. For you, Margaret, you lost a breast many years ago, but that has not put a stop to your daily living. What do you advise other ladies who hear that a mastectomy is probable, or society members who look at a woman that she's not enough because she's lost parts of her?
Well, there I would say, when I lost my breast, I was in a trading center, and so the other ladies were telling men she has one breast. So the ladies saw me as valueless, but men are very good. They still came to my hotel, and I gave them service, and said they were comforting me. Don't mind. Take it easy. You are still Margaret. You are still a mother. You are still a grandmother now. Even now, I'm approaching to be a great-grandmother, and I'm happy for that. For the breast, I forgot I had 2 breasts. I do see as if I was born like that. I don't mind if you talk, you'll talk and then keep quiet. So I don't mind about the breast. What I mind about is my grandchildren and my daughter.
Okay, and when you're walking with others that are in the same support group with you, what do you remind them of in as far as seeking the right support system around them?
Well, now this time there are young ladies who are coming to the support group. Still they have their husbands, they have their small children. I do tell them, take care of yourself so that you can take care of your children, your husband, and your family, and still you are valuable to the community and the country. Don't say that if you don't have a breast, you can't do anything. Do anything you can.
Very true, very true. Now, Otanga, you have reached out to the masses to help you raise this 4 million shillings you need to go to India for further treatment. And most people would rather keep quiet till the end and not ask for help. You have gotten to that point. What would you like to tell others who feel kuuliza itakuwa kama burden kwa wengine?
Yeah, it's a challenge for a man to beg. It's like begging, but he can appeal to make it sound better. But for treatment for a man, you see, it becomes a burden. Like for now, on my side, it has come on a very bad period. We had Corona, and boom, the schools are open in January. Everyone is saying shule zimefunguliwa, the kids are going to school. Now raising funds is becoming a challenge. But on the side of being a man and keeping quiet, it's normal for a man to not to go around talking about his medical condition and problems, because the moment it's not good, because the moment someone sees you, it becomes like a stigma. People try to avoid you, they won't pick your calls. But now that's the nature of a man. But for now, me on my side, I just come out to make an appeal for anyone wishing to support me on this journey, maybe to go to India to get my condition taken care of. I'll appreciate for now.
All right, thank you. Thank you for being so candid. Now, Christine, these are conversations you have on a daily, even as you engage with the different networks that are under the umbrella of KENCO. Your parting shot.
Well, for me, you talked about psychosocial support. We continuously encourage patients, once you get to know your diagnosis, please get yourself into a support group. KENCO members are all over across the country. It is very helpful to get support from somebody who's currently undergoing that condition. You'll be able to discuss about your fears, you'll be able to discuss about your side effects, and you'll get hope to know that actually others have made it and there is hope for you. Number two, we call upon public members, please get to know the risk factors, get to know the behavioral risk factors, the ones that are really on your hands, that the ones that you can manage. Reduce intake of alcohol, reduce intake of tobacco, eat a healthy diet, do your exercise in order to prevent cancer. You also need to go for regular screening. We have current screening guidelines, so you need to go for regular screening. The health workers, we encourage you, please get to suspect cancer early enough for the sake of that patient. On government, we ask that you need to set aside resources for this. We have some of these risk factors that I mentioned. We have a lot of sin tax that can be generated from tobacco, from alcohol, and from fast foods. When you raise the taxes, you reduce the consumption of these products, and this money can be diverted into the non-communicable diseases area. And for all of us as a nation, we need a multi-sectoral approach to cancer. Each one has a role that you can play for the sake of reducing this scourge. Thank you.
All right, thank you for that. And of course, the theme this year actually is that everyone has a role to play when it comes to dealing with cancer. And Dr. Sidna, I mentioned the importance of research in this conversation. I mean, they say prevention is better than cure, and I think research plays a huge role when it comes to prevention. And the Gachanja University Hospital actually set up a cancer center, or rather research center. Right. What is the role of this, and how can it come to help us as a country?
So, like you said, knowing your problem is the first thing, so that the cancer problem in Kenya might be the same, but it's not similar to what's happening around the world, right? You mentioned that we have breast cancer patients who are much younger than the rest of the world. So we need to understand why that is the case. Mm-hmm. So the Cancer Research Unit is a unit set up by my boss, Professor Mansour Saleh. And the idea is to know more about why people in Kenya are getting cancer and what are the things that we can do to improve their outcome, and also to allow treatments that are not readily available to be available. So part of it is bringing clinical trials of drugs that are being tried outside the country so that our patients can also benefit from those drugs. It's not just things that we read about in the literature, but there are things that we can actually do for our patients here. So there's a lot that needs to be done in terms of research for cancer in Kenya, and we are hoping to be the pioneers in that. And just to say that we are also thinking about starting a stem cell transplant that we talked about, and this is kind of like within a 3-year span, something that we're going to develop in Aga Khan.
All right, Dr. Sitner, Oncology at the Aga Khan University Hospital. Thank you for your time and a lot of knowledge in as far as these cancers are concerned. And our survivors, that is Edgar, Margaret and John, we wish you good health and wellness even as you seek treatment and keep on beating cancer. And of course, Christine, you stand here on behalf of a huge network of stakeholders who are willing to stand in the gap and ensure that those that walk in these shoes have a better quality of life. Well, that is it from us here at Your World. Tomorrow morning, I'll be back with a different conversation. This time round, we'll be talking about parenting and we'll be zeroing into fatherhood. And to be more specific, present fatherhood. It has been said, it is one thing to be a father, it's another one to be a present father. So what exactly does present fatherhood mean? And also, what are the repercussions if you do not take care or walk with your kids in their journey? Well, we'll talk more about that tomorrow. See you then.
Akili, 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 akili. Let's chase the germs away. Let's chase the germs away by keeping our hands clean. And when you want to sneeze or when you want to cough, do it in your elbow. Let's practice sneezing into your elbow. Are you ready? 1, 2, 3. Achoo! Again. Achoo! Yay! You did it! Germs, germs, germs. They make us sick. Germs, germs, germs are not our friends. Germs, germs, germs. They make us sick. Germs, germs, germs. Germs, germs, germs are not your friends.
Credo Mix is all about anything created artistically by us, for us. Music reviews. Feel the fresh vibes full of surprises as we get interactive with your favorite artists and celebrities exclusively. We will bring you all the latest hits, trending topics, and the weekly top 10 every weekday from 5 to 6.
And you're watching Credo Mix on NTV. Keep it locked.
Thank you so much. Thank you. Thank you. Thank you.
Thank you, Untitled Chapter.
Thank you for making us. Thank you for making us your favorite drive show crew. Nation FM, we love you. Oh, thank you, people. This is the best I'm stitching. I got you good.
Nyinyi jamaa mmetizi yani. Tunajibamba na show yenyu. Muendelee hivyo hivyo.